Good morning, colleagues, and welcome to the July public board meeting. And pleased you were all able to make it. We have a welcome today. I'm very pleased to welcome Steve Hackett, our new Director of Finance, who started with us on the 1st of July. And you're very welcome, Steve, and we're all looking very much to working with you. And we're very pleased that you enjoyed and was able to attend our board development day earlier this week. So good to have you on board.
Thank you, Chair.
We have a couple of apologies for today. We've got George Briggs, James Rawlinson, and has Michael Wright been able to join us? Well, we'll take Michael's apologies until he is able to join. Any further apologies, please, colleagues? Right, thank you. We are quorate. Having read the board papers, colleagues, has anybody identified any conflict of interest or potential conflict of interest in any way? If not, as usual, as the debate continues, if you think there is one, then please highlight it for us. Thank you. We have got the minutes of our previous meeting held on the 4th of June attached to our papers. Are they a correct record? Right, Heather?
Just one on page 7, the second paragraph up from the bottom. I think it should say report rather than reported. It's just minor.
Okay, thank you. Any sort of minor typos, we'll just, if you can take those separately. It's the body of the actual decisions that we've taken and that the narrative is right. Are we all comfortable with that? Right, thank you. So all agreed. Any matters arising from those minutes that don't appear anywhere else on our agenda? Okay, if we could now go to page 15 of our pack to the action log, that would be good. Right. So you have them in front of you. We'll take the first one, which is let me get the number of this one, number 12. That's not now going to be done until September, so we'll note that. And 29 to 32 on the action log are proposed to be closed. Are we all comfortable with that recommendation? All agreed? Thank you very much. Have we got our colleague who's joining us for the staff story as yet?
I can't see Martin.
Sorry, Martin, it's Dawn. The staff story has been stood down this month due to the technical difficulties on site.
Okay, thank you. We'll just note that then. Well, thank you for the preparation, and I'm sorry we've missed that, but we'll take that at a future date then. Thank you. Let's now move on to the first substantive item on our agenda then, which is page 16, the Responsible Officer's Annual Report and Statement of Compliance. Dr. Callum Gardner, our Medical Director. Callum.
Thank you, Chair. Hopefully the report itself is self-explanatory for board colleagues, but I think the key things to draw to your attention are every year organisations have to submit an annual organisational audit, an AOA. This last year was not a requirement. The report, and indeed we're one of the few trusts to do so. A lot of trusts stood down appraisal in line with the National Medical Director, Steve Powis' directive. We, however, as I've said before, continued to offer appraisals from a supportive point of view and closed the financial year at 92%, which was, I think, really, really good, and indeed an improvement on, a sustained improvement on the previous year. And the final thing just to highlight is that we are rolling out this year e-appraisal, which is, we already have a good electronic system through something called MagForm for appraisal, but this is a rollout of it through the Allocate module, which many of you will be aware is going to be used for things like e-rostering and many other things. So it's bringing it onto the one platform, and the intention is to roll that out this financial year. Otherwise, very happy to take any questions, Chair.
You're on mute, Martin.
Lynn, we have a question from Lynn Haggett. Lynn?
Yes, just to say, Callum, I think it's a very positive report and very pleased to see the things that you carried on doing that you didn't need to. I think that's great commitment. This is probably a rhetorical question, but are there action plans and ongoing monitoring hanging beneath this? I'm just thinking by way of example, there's concerns about data flows. Just wondering what's been done about that.
Yeah, there's not an overarching action plan as such, but these actions are very much in train. So that's more about, and I think we have significantly improved in the last couple of years since I've been here, the data flow to do with serious incidents and complaints. It's just strengthening further. So for example, around complaints, I get a monthly report every month from the patient experience team with the complaint numbers, the doctors, dentists that were named in them, so that I can then make sure that they are reflected upon in their appraisal. And I can also check that they have been received. Where I think we need to strengthen further is they are not always being made aware that there's been a complaint, and they're not always being offered the opportunity to respond to the complaint, which is clearly really important, separate though arguably to the appraisal process. And the same is similar to the serious incident process, where I get a list and then can therefore make sure, as is the requirement from an appraisal perspective, that they're appropriately reflecting on any serious incidents or complaints that they might have been involved in year. So it's more strengthening that process rather than the appraisal process per se. But those actions are very much in hand, and I'm discussing with patient safety team, patient experience team to see how we can strengthen that. And I'm also spot checking with colleagues. So when I get the list, I will drop a few of them a line just to say, can you confirm that you got this complaint and you were involved in the response, just to make sure that that is indeed happening.
Thank you for that clarification, Callum. Anyone else? Can't see that. No one else, is there? No. Well, thank you, Callum, for your report, and also thank you for attempting to do as much of the appraisal process as you possibly could during the last 12 months. I'm sure that's been a very positive step. So thank you for that. If we go to the recommendations, it's recommended that the board approves the report and the statement of compliance. All agreed? Agreed? Thank you very much. Let's now go to the page 25, the report from the chairman. If we can go to that item, please. Right, there's a couple of items in this report that we need to make some decisions on, but before we do, we'll leave the health inequalities and the updated net rolls. Any other comments or questions on the report? I've got, just bear with me. I've got Lynn. Lynn?
Yeah. Okay, there's a number of matters, Chair, so apologies in advance, but reading my section, it should be continuity of care and not continuity of career. There's a section missing that I submitted on my attendance at the whole day annual perinatal mortality review event, and I think that's important for assurance, because in that I tried to outline how open, honest and rigorous that process was. So I think that's important, that's included. The Australian modelling, there's a missing word, it's paediatrics, in relation to paediatrics. So I've got a number of questions that people, if they could address them now, that would be great, or if we could take it offline, if I may raise those. So this predicted surge is pretty significant, and I've heard mention that we might need to utilise our adult ICU beds if that materialises, and I get a sense that you know, this surge is already starting. So I'd like some clarification on that, please. Also on the point from the Integrated Sexual Health Service on GPs pulling back from implantation services, and it's sort of detracting that service from doing some key work. I'd like to know a bit more about how, I've asked this before, I'd like an update on the ring fencing of gynae beds, because clearly that's key in terms of our recovery. Where we are on the NICE guidance non-compliance in relation to transition, because I suspect this is going to come up in the SEND inspection that's been going on. And also the point I've made about the autism block contract, there seems to be some uncertainty around there about who's responsible.
Okay, Lynn, a few items there. Are any of our colleagues able to respond to any of those points, please? Anybody want to do that, or do you want to take those offline? I can't. Sorry, thank you, Angela.
Apologies, I was struggling to put my hand up.
No, that's okay, thanks.
Just to reply regarding the paediatric surge that we're expecting post the experience in Australia, we are having meetings to identify what the potential impact will be on us. We are seeing increases of tendencies from children with respiratory symptoms, and we are looking at whether we do in the future need to use those paediatric patients within ITU adult areas, and there is an ICS wide steering group that's been set up around that. We're also having conversations on a local level, identifying what staff we have within different areas of the organisation that potentially could staff paediatric beds within an general ITU, and obviously the work we did around COVID, with it being respiratory, we have got that information around the kind of staff and the placement of staff around the organisation should we need to pull them in more centrally. We're also looking from a UECC point of view, how we will put those patients through the paediatric area and cascade them through up to CAU and in those areas. So we do have a substantial plan for us to manage it. Obviously, we don't know the numbers that we will be dealing with. It is a little bit of an unknown, but we are certainly prepared for it and making things as safe as possible should it hit us very hard.
Thank you, Angela. I think Dr. Callum and then Sally, please.
Thank you, Chair. Just in reference to the NICE guidance, I think from memory, this one of it transitions to do with diabetes care. Colleagues will recall that we approved a business case for an extra and 11th full-time equivalent paediatrician, future standards, and one of the requirements in the business case was to support transition services around diabetes. Not only did we appoint one consultant, we actually appointed two at point 8, so we got 2 new consultants, and we also now have a 4th diabetes consultant as well, again on the back of supporting and improving transitional care. And as an organisation, we're also looking at trying strengthening the diabetes specialist nurse. So there is work in train to really try and strengthen transitional care in the broadest sense in paediatrics, but in particular relevant to this NICE guidance in diabetes management.
Thank you, Callum. Sally?
Thank you. I was going to respond on the RSV and paediatrics, which Angela's covered. The only other thing I would add on that is that, just to give assurance, it's a significant part of our winter planning operationally, and we're working with partners locally as well as Angela outlines the ICS. There's an ODN plan being worked up across the ICS. In relation to the ring fencing of gynae beds, we're working hard to achieve that. One of the challenges we've currently got is the significant increase we've seen in non-elective demand and urgent care. But the plan that we're working through in the medium term as we head towards winter is some estates work to move some of the ward capacity around to give us different capacity in terms of our elective capacity to enable us to ring fence it, and more flexibility about how we use those beds, and particularly around orthopaedics. So there's some estates work underway as an enabler to that, and we're just pulling that together in terms of a plan so that it's really clear about which wards will be where and how they'll be located. And we're working through the general managers to deliver that in a joined up way. So we can bring that update back through in terms of where those ward moves that will deliver that ring fence capacity.
Thank you. There was just a couple of other items. One was about sexual health and the other one about autism. Anything anyone can add to that, or will you take that offline? We take those 2 points offline, can we? Thank you.
Please.
Yeah. Okay there, Lynn? Right. Any other comments on any item on the paper? Steve?
Thanks, Chair. I just thought it was worth noting on the big tea party how well that went, and I think it's probably worth recognising the work of Ian's team in making sure that the garden was ready, because I was slightly sceptical. It's outside my office, but the team pulled off a tremendous effort, and to Emma and her team as well, because I think staff really appreciated the big tea party. So I just thought it was worth acknowledging you board.
Absolutely. Thank you for doing that, Steve. And let's record those thanks. And I'd also like to add to that the support given to the development of the garden by Heather Craven and the working group and a group of colleagues who've got together there. So thank you for that. And for everyone who participated. It seems to have been an excellent day and actually met what the objective was of actually giving a big thank you to our colleagues and leaving them with a legacy that hopefully they will enjoy for many years to come. So thank you to that. I'd like to now pick up the items where we need a decision on, please. And that is, the first one is the health inequalities task and finish group, which is being proposed. And first of all, I would like agreement to the terms of reference as attached, and then I'll come on to the proposed membership. So everyone's had a chance to read it. Are we all comfortable with the terms of reference? Can I take your agreement for that? Is there anybody wanting? Oh, sorry, I've got a couple of hands up. Just bear with me. I'll see whose hand was up first. Joe and then Richard.
Yeah, thanks, Martin. And obviously, as you know, I sort of was involved in drafting the terms of reference. There's just one change, I think, from the draft we initially put together in terms of the draft that's come to the board, and that's on duties and responsibilities. Item 4 refers to service users. I think everything that's said there is highly relevant and actually relates, I would say, to item 2. But what we had initially drafted was looking at staff, inequalities in health amongst staff. And I just, obviously there's been some thought on this and be interesting to know why that was modified. But just to say, I mean, the NHS, it's a large employer in the region. So and it's an organisation that we know as nationally the profile of it, there is high levels of poor health, high levels of obesity, for instance. So I think kind of to ignore the staff group in this context and the opportunity that that gives to influence the wider community would be a missed opportunity. I know there's other places where staff wellbeing is considered, but I just think it's an important area for us to be paying attention to. So I wanted to raise that. Okay, thank you. Well, Richard, you're to go next, and I don't know whether you can pick that item up or one of your colleagues can, because I know you've discussed this at the executive team. Thank you.
Yeah, I'll have a go. And it does link to the point I was going to make, so that's that. I think that. So I guess I'd welcome the group. I think it's definitely going to be very helpful, and I think it's something that we need to do. We had a discussion around that issue that Joe's raised at the executive team when we had a look at these terms of reference, and there were a couple of things that led to us suggesting that this focus on patients and service users rather than staff, partly because we have a lot of other fora looking at staff health and well-being. We've got the people committee, we've got all sorts of other pieces of work we're doing there. Our staff are also predominantly Rotherham residents, so work for the local population, patients, users, service users would catch those staff to some degree. But also there's a sense that actually it's a pretty big agenda, and trying to do all of that in one go might detract from the focus on patients, which we felt was if you had to choose one or the other, that felt like the more important of the two. But clearly there's not a right answer to that, and that was just what we felt at that time. That does come on to the point I was going to ask also, which is just, I think it's picked up to some degree in the terms of reference, but it feels a little unclear to me about how the work of this group will translate into action. So, how do we then, how do we make sure that the findings, recommendations of this group then influence how we manage the services locally and how we make those decisions there? So it reports to board. So, I mean, the way it's described in here, and I'll perhaps test how I think it would work. So the group does its duties under the terms of reference. It reports to board, and then board directs the executive to act. I think that's how it feels. And I just wondered if that's for some of the things that feels like quite a cumbersome route to go by. And actually there might be quite a number of simple lower level actions that wouldn't need all to go through that to board to be affected. And I just thought that might be worth just thinking through whether or not that would slow it down, particularly as we sort of moving towards 6 board meetings a year. So that was my reflections.
Okay, thank you. Anyone else? Right. Cameron?
Yes, thank you, Chair. I was just trying to get from the paper where we are on the journey here. So are we at right at the beginning where we're trying to identify what inequalities we may have at the trust in the way we offer care and therefore the scale of the job in hand? Or have we got past that and we kind of know the size of the challenge and therefore we're into sort of trying to find solutions? It wasn't clear to me where we are on the journey and therefore the scope and scale of the work ahead of us.
Okay, anybody want to come back on that? From a personal point of view, I would imagine that there's a bit of both, Cameron, like there often is in these situations. We know some things, but we don't know what we don't know as well. And therefore, the Task and Finish group has got a license really to actually get us to that position of knowing what our challenges actually are. So I'm imagining that's what the group will actually be doing. So we've given them a remit to very much focus on doing something about that which we can control within the services that we provide. So I'm hopeful that that's going to be the case. Michael has joined us, so welcome, Michael.
Thank you, Chair. Apologies for my lateness. Yeah, absolutely agree with the point you've just raised. I think there will be certain things that we can influence and expedite, but acknowledging that we are part of the system, so we will continue to work with the system as well on health inequalities.
Michael, now you're here, in response to Richard's point, it seems to me the point that Richard made is that there's some things that might be identified and can actually be moved on very quickly and responded to through the executive machinery, as opposed to it tortuously going through the board first. And I would have thought is that you are going to be a member of this Health Inequalities Task and Finish group. And if the board is agreeable, I'm sure we can rely upon the Task and Finish group through Michael as our Deputy Chief Executive to raise matters through the executive team and actually get them progressing and then report to the board as the work goes on, if we'd be agreeable with that. That seem reasonable as a way forward? If we could capture that in the minutes, please, that picks up Richard's point, and the fact is that we will accept as a board that there will be some operational issues that, when identified, can and should be progressed through the executives and then reported to the board accordingly. Right, are we comfortable with Richard's explanation about not including staff specifically at this stage? Because that was a point that Joe had made and the executive team had come up with that particular approach. Are we comfortable with Richard's suggestion? Are you wanting to add something, Rumit?
Yeah, just in response to that, Martin, I think the reason why we went down the route of health and well-being of staff was that we've got quite a captive audience within our trust. And I appreciate what Richard's saying, that they are Rotherham residents and therefore they may well also be in the system in terms of the health needs, etc. But I think it was a captive audience that we perhaps thought may actually have a wider influence in that they may influence their own families to look at healthy lifestyles. So I think it's a difficult one, I understand, because it's such a broad agenda, but to have that focus was quite important when we discussed it at the first meeting.
Richard?
Yeah, so are we clear the difference between this group's remit and the general health and well-being for staff work that we're going to be doing?
Steve?
Yeah, I think I was going to make a similar point to Richard, and I suppose it's worth saying that one of our prime objectives this year is the health and well-being of staff, and so we are putting a lot of effort and energy into that. And I think part of the debate as well was about scarce resources and the ability to focus on that objective without being distracted. I know it's not a distraction in that sense, but in terms of the limited resources that we have, I think we were keen on just focusing on the objective that we have around staff health and well-being as a prime concern.
Thank you, Joe.
Yeah, I was just two things I was going to mention. I mean, one is I think actually sort of staff health and well-being is probably also implicit in the anchor work. So I kind of think these things will get touched on through some of the other areas. But I guess that what might be different about the conversation this group just wants to have, and I think it does need to be had, is any inequalities aspects of, the staff wellbeing programme. So that might be a question that this group asks: is it having inadvertent consequences for health inequalities in terms of how the uptake of the programme or the focus of the programme? Seems a question that's worth exploring if it's not being done through the main programme.
Thank you. Rumit?
Yeah, Steve, are you able to actually just explain what the health and well-being sort of staff agenda is? What exactly are you going to be doing with health and well-being of the staff specifically?
I could, but it might take a long time. So through People Committee, we've heard quite a lot around what we're doing, partly as arising out of the pandemic in terms of supporting staff health and well-being, both psychological and physical. And as we move on to try and meet the objective that we've set ourselves this year, we've already been successful in getting a grant from the ICS around physical health and well-being, particularly around dietary needs, around healthy eating, etc. So we're going to be setting up something to do with that. So I'm only touching on the surface there, and I think hopefully Lynn will recognise that we are taking quite a lot of that through People Committee in terms of assurance around health and well-being.
Okay, right. Well, thank you for all your contributions, colleagues. What we'll do, we'll leave the terms of reference as they are. However, if during the conversations through the task and finish group, the kind of question that Joe has mentioned, that there is questioning the health inequalities around staff and health and well-being as that emerges, we've got the appropriate representation on the task and finish group. If that becomes an issue, that's for Michael to take to the executive team and Joe to bring to me, to my attention, and then Richard and I will have a further conversation about how we might manage that. But I think if we can collectively as a board recognise is that our executive colleagues have been considering the setting up of a new group and the impact on the capacity of the organisation to be able to support the work. So I'd like to go along with the proposal at this stage, but I don't want it to inhibit the work of the group. So if it becomes an issue during the conversations, then let's address it at that point in time. Thank you for that. With those comments there, can I seek your approval of the terms of reference for the task and finish group? All agreed? Thank you. I'd now like your approval for the membership of the task and finish group. The membership is proposed as the 3 non-executive directors will be Joe Bibby, Rumit Shah and Nicola Bancroft, and Joe will be the chair of the task and finish group. In addition, there are 2 places for executive directors, and it is proposed that they go to Michael Wright and Steve Hackett. Those are the proposed names for the task and finish group. All agreed? Thank you. Thanks very much. If we now go back to the paper, there's one other recommendation. Appendix 2 is the updated list of NED lead roles, which are attached. And I do want to emphasise that there is a national review going on about NED lead roles that I mentioned to you before. It was expected to have been reported sooner than now, but it hasn't been done, and that is still work ongoing. I think with all the changes that are going on with regard to NHSE and NHSI, this has not been a particular high priority, but it is expected in the next couple of months. So we may revise those lead roles again going forward. But I seek your approval for the lead roles as nominated on the attached document. All agreed? Thank you very much. Let me now move on to the page 38 of our agenda, which is the report of our Chief Executive. Richard?
Thank you, Chair. I'll take the report as read. Just two things I'd perhaps expand on slightly. The vaccination programme, there's considerable uncertainty about what the ask will be of us, and some waiting to understand whether that will be also an ask to deliver the annual flu vaccination concomitantly with the delivery of a booster jab for COVID. We don't normally give flu vaccination to the wider health and social care staff in Rotherham. We normally do it for our own staff, so that would be an additional challenge. And if it was 2 jabs in one sitting, that might not be much more of a challenge, but if it was separate jabs at separate times, that's quite a lot more work. So there's quite a lot to work through that, and it would depend what the national ask is. The second issue that we just got updated on yesterday is the threshold for the elective recovery fund as part of the recovery funding for the work we're doing has been raised to 95% from 85%. So board colleagues will recall originally it was 85% for July. We learnt yesterday through our Stephen Stewart that it's now going to be 95%. I think our understanding is that there's been very good achievement nationally of that elective recovery fund, and I think therefore raising the bar in terms of the funding that trusts can access. Otherwise, Chair, I'm happy to take any questions.
Thank you, Richard. Any questions of Richard, please? Heather?
Thank you. Could I ask Richard about something that's included in the ICS Chief Exec report, which is about the setting up of the diagnostic hubs, and there's an ICS submission. And I just wondered what was in that submission and what the implications are for our hospital and the diagnostic hub for us, particularly in view of some of the proposals that we may be discussing later.
So the ICS-wide bids, there's 2 gone in, and there was very short notice business case turnaround deadline yesterday. One bid is for a hub based at the Montague Hospital in Mexborough, which for those who are less familiar with the geography, that's almost equidistant from Rotherham Hospital, Barnsley Hospital and Doncaster Royal Infirmary. And it's in the heart of a very deprived community. I used to work there a long time ago, so I think it's quite a good place to put diagnostic facilities to reach a population that's otherwise quite would struggle to reach main hospital. So that's and the other one is in a building called the Glassworks in the centre of Barnsley, where there's a proposal for diagnostic facilities including breast screening, phlebotomy, simple imaging. Those are the 2 bids that are going forwards. There's again considerable uncertainty about the funding arrangements for those bids in terms of the running costs from revenue point of view. I think it's after the first 1 or 2 years, and but I think the view is that this current round of bidding for community diagnostic hubs is likely to be followed up by these becoming much more mainstream in the future. So although there isn't one yet for the Rotherham place, I think it's likely to be the case that there'll be an expectation of far more community diagnostic hubs in the future.
Thank you, Richard. I've got Rumit, Joe and Stuart. Rumit?
So Richard, with regards to the elective recovery fund, how are our other partners in the ICS doing in terms of recovery? Are we also reaching the same sort of target levels, or?
Would you mind if I ask Louise to answer that question? I hope I don't put it on the spot, but Louise has been quite close to the shared performance.
Thanks, Richard. So really, I think we're similar across the patch. Some of our other provider trusts are potentially doing more in terms of inpatient activity, others are doing more in terms of outpatient activity. So it is a bit variable across the different points of delivery, but in general, we're all delivering above the 85%. I think, as Richard's pointed out, that the challenge is going to be in July now with the 95% the increase to 95%. The bit that's working in our favour, I suppose, is given that was actually only announced to us yesterday after the start of the month, is that because we're part of an accelerator system, we're all actually aiming for 100%, and we're doing for July anyway. So in some ways, we're a bit ahead of the game as a system around that. But I do think getting to that 95% for the whole system will still be a challenge and is a big ask for the month of July, particularly given the non-elective demand we've seen. I don't know if any of you saw in the press yesterday, but there's been a lot of press around, busiest month ever in June, and that's continuing in July, and we're only a week in, but that's not abated in recent days. So I think, particularly given that, actually increasing that target to the 95% is going to be a challenge for everybody, I'm sure.
Thank you, Louise. Joe, Stuart, and then Michael Smith.
Thank you. Yeah, I had two questions. One was just on what might be the implications of a further surge in COVID cases on elective care and elective recovery, and I just wondered if it was possible to hear anything about how the effects of that are likely to be mitigated. And then the second question was just going back to staff vaccinations, and what level of staff do we know have had both vaccines now, and what do we know about the staff who haven't had them, again coming at that from an inequalities aspect.
Thank you, Joe. I'll pick up the COVID one. I'll ask Steve to then address the vaccination stats, if that's okay. What we're seeing in COVID at the moment is we're seeing a progressive rise in prevalence in the community. Across the patch, that is most marked in the Barnsley in South Yorkshire and Bassetlaw, where the rate per 100,000 is about 550 at the moment. The latest rate for Rotherham I've seen is between 200 and 250, but that may be lagging slightly as well now. We are starting to see a small but steady rise in inpatient numbers. And I think what we've seen across the rest of the north is that the hospital activity is going up following the community prevalence going up. And that seems like an obvious thing to say, but it isn't the same as in earlier waves with the impact of vaccination. So we're seeing an attenuation of the relationship between community prevalence and hospital prevalence. But there is clearly a relationship. So just locally, Barnsley's up to about 20 cases now. I think Rotherham was 8 or 9 yesterday. Barnsley started to got 4 in critical care. I think Rotherham's got 1 in critical care. So Rotherham is lagging behind Barnsley, which is good. I think we're seeing similar patterns in Doncaster and Sheffield to Rotherham because they've got a similar prevalence rate. But what we've seen in West Yorkshire and parts of Lancashire is a steady rise. We don't know how high that's going to go because, of course, there is quite high community prevalence, so quite high community achievement of vaccination rates. So the Rotherham place has been at about 75% of the eligible vaccinatable population in about a month ago, and they've obviously progressed since then. But we also know that AstraZeneca vaccine isn't 100% protective against the Delta variant. So it's really hard, Joe, to predict what the numbers will be. I think my guess is we'll end up peaking between 20 and 40 COVID positive inpatients, and that's a guess. I could be wrong in any number of directions from that prediction. A bigger issue at the moment for us than the numbers is the impact on staff. So what we're finding at the moment is we are losing a lot of staff, and the other trusts saying the same thing, to having to isolate because of either contact themselves or because their children have been a contact and have been sent home from school and having to isolate that way. I think there's at least one person on this call who had that to go through that yesterday. My son's been isolating for 10 days recently, fortunately negative. So that is really affecting our ability to deliver services. We have had to cancel, we picked up an exec team yesterday, we had to cancel some orthopedic elective cases recently on the back of some of these issues. And I think there is a real risk that if this progresses, and particularly with the complete cessation of the legal restrictions, I think my personal view is things will get worse before they get better, and that will start to compromise our ability to do elective recovery, unfortunately. And Steve, would you mind just picking up the latest vaccine stats, please?
Yeah, so from a staff perspective, we're just short of 80% of staff who have had both vaccinations. That's not a 100% accurate figure because we do know that some staff have had vaccinations elsewhere in terms of our record keeping. we're just going through a process of checking with staff who we are recording as not had the vaccine, that A, they've had it, and B, if they haven't, doing some having some positive conversations with them about the value of the vaccine from a staff welfare point of view, but also from a patient safety perspective. So we're actually targeting those individuals who haven't had it. I think your second question, Joe, was about the staff groups that haven't been taking up the vaccine. So what we know in terms of staff group is medical and dental staff are the staff with the lowest uptake of vaccine. I think I could probably phrase that a different way, because I think medical and dental staff are overrepresented in terms of Black and ethnic minority staff as well. So I think it's a feature of the national vaccine hesitancy amongst Black and minority ethnic staff. But again, we're having those positive conversations with those staff to ensure that we do have as much uptake as we can. And partly from a record keeping point of view, given what Richard was saying about the prospects of a booster dose between September and December, we want to make sure that we've got 100% accurate records of who has and hasn't had both doses, so that we can target those people for the booster jab as well.
Thank you, Steve. Stuart and then Michael Smith.
Good morning, thank you, Martin. Just a quick one on 1.4 of your report, which you talked about, obviously the volume going through UECC, and I just wanted to check, are we seeing all the normal support we would see from our partners locally and across the ICS, that we'd sort of seen the depths of the winter pressures to help us with our sort of UECC position?
I think there's more that we would be looking for our partners to do to support us, and this came up in our executive team discussions yesterday. So particularly around support for those patients who've got a long length of stay, or who are waiting social assessments for placements outside of the hospital. So the people who essentially are no longer needing hospital care for their medical problems. Those numbers are higher than we would like them to be. Certainly historically they're better now than they used to be, but they're not as good as they could be. And so we agreed yesterday that we would escalate that for further support, because of course more pressure on the front end is difficult to deal with, but we need to make sure the flow through the whole system is efficient, so that people who don't need hospital care are not preventing people who do need it from accessing a bed in a timely and safe way. So that's something we'll be talking to our partners about.
Thank you. Michael Smith.
Thank you, Chairman. I've got two questions. The first one is about the elective surgery and the effect on staff. I'm not thinking necessarily about the frontline staff here. I'm thinking about the people who have to manage these processes, and the fact that they're trying to, in the Yorkshire expression, platch fog, and what support we're giving to our managers at senior and junior level. The second one, if I may, is about car parking. And just thinking about the communications, we are where we are with it. It's an ICS-wide issue, and I'm just wondering whether there might be some advantage in communications terms to doing a joint press release, so that it's hospitals across South Yorkshire are, rather than Rotherham Hospital is. So those are my two questions.
Thank you, Michael. Richard, please.
Yeah, thank you, Michael. With regard to the car parking one first, I think that's a very sensible suggestion, and certainly I would suggest that Emma and Ian, who are leading on it from a comms and car parking point of view, pick that up with opposite number of colleagues. Secondly, in terms of supporting the sort of, I think your question was getting at the sort of management staff who are trying to coordinate this really rather difficult issue. Louise, George, Sally are working very closely with those teams. It is very difficult, and it's a key part of the reviews we do through the performance meetings regularly. I don't know if any colleagues want to pick up more in any more detail, particularly Louise or Sally, in terms of how we're supporting, it's particularly the Division of Surgery, isn't it, who are in the front line of this.
It is. I'm happy to come in on that. There's a lot of work that they're doing, and obviously it links to the wellbeing work, and what we've had discussions around that equally applies to our managers and senior managers, and particularly some of the admin staff that are working hard alongside this. I think particularly surgery are impacted, and surgery have done a lot of work with Sarah Newbold, who's our head of health and wellbeing, with them as a leadership team as well. And I think I highlighted at Finance Performance Committee, one of the highlights of performance reviews for me was the surgical division and how they talked about the work that they're doing and how they're working through 5 ways to wellness. There's visibility of the senior team out with their more junior managers and colleagues. They're all making individual commitments as to what they will do to support health and wellbeing of their staff. We then have had that discussion with the GMs and heads of nursing about how we do that. And Sarah's joining us through that forum in terms of the senior leadership team to work with them. She's actually responded to me this morning to set that up. We're equally working with the senior managers as well as more junior management staff. And we have had some positive feedback around the impact that that's having.
Thank you, Sally. Emma, would you like to contribute?
Thank you. Yes, just in relation to the car parking and the communications element, we are, wherever possible, putting out sort of joint messages across the region. And we actually met as a region yesterday in terms of communications directors. With the car parking, it's a little bit tricky because not all hospitals are doing the same. So Barnsley, for instance, can't implement car parking charges just due to some building works that are happening. So it is difficult to get a regional piece on that. But I am making sure that the messages are aligned with what other trusts have put out.
Okay, thank you. That's all the comments on Richard's paper. I think if we refer to car parking and just mention is that we are reintroducing charges for patients and visitors with effect from the 19th of July. So we'll note that position. All done on Richard's report? Thank you. Thank you for your report, Richard. Let's now move to the development of our strategy, page 49, and this is an information report. And Louise, you're just going to update the board on progress on this item. Thank you.
Thank you, Chair. Please do note if my signal does cut out, Chair, please let me know, but I will start and hopefully be okay. So this is just an update from the work we've been doing for the last few months, which the board have been heavily involved with in terms of updating our new trust strategy with the intention that we will complete that by the end of Q2 this year. And the note just provides more detail on the work we've done so far and where we're going over the next few weeks. So I'll just pull out a couple of areas for highlight. The first one is just in terms of the process. The chart on page 51 just gives you a sense of what we've been focusing on for the last 2 months, which has been really around internal board level and senior leadership level engagement. And we've been running a number of workshops and discussion forums with different colleagues to get feedback from them and views from them on our priorities over the next few years. But we're now moving into that phase of wider engagement and thinking about how we connect more broadly with our workforce on this. And so we're starting a series of development sessions over the next few weeks. The first one is in fact on Monday. We've got 5 virtual sessions and then we've got a couple of longer drop-in face-to-face sessions as well in the organisation to ensure that we can get that broader input from staff and colleagues. And at the same time, we'll also be moving on to a more engagement with our partners, and there'll be a number of us involved in that conversation as well to make sure that we can involve them in the development of our strategy over the next few months. And then as it notes, just looking to a plan to have this finalised at the end of Q2. So that's the process we're going through. I think there's also just a bit of an update on the emerging themes, which the board we've had conversations about already, but I think it's interesting to note we're all kind of convalescing around the same priorities for the organisation. So the first one, which I suppose is fairly the fundamental that we're all here is around providing to our patients and to our wider population as well. And the conversations we've had have focused on, I suppose, our advantage as a integrated trust and how we can utilise that more effectively and think about how that can drive us going forward over the next 5 years. And we were talking about that again at exec team yesterday, but making sure we're maximising those opportunities and thinking of innovative ways to provide care in potentially slightly different ways through that integration that we've got in the organisation. The second area that has definitely emerged as a priority and a theme has been around, we talked about it, around the concept of us as an anchor institution. And I think in terms of when that plays out to the wider public and the wider staff, that will be around some specific things that we can do differently as an organisation, but also as individuals within the organisation, to make sure that we're providing that broader role to society. So that's our second theme. The third one is around, again, partnerships and collaboration, which connects to the second one, but just I think given the national changes that are afoot, very much afoot at the moment, this is really, and it has been critical for the last few years, but this is going to be important over the next 12, 24 months in terms of how those play out and our role in that wider system conversation, and how we are using our position to really influence that discussion and take that forward. So that's the third theme. The fourth one is front and centre of everything we do, isn't it? But again, we've referenced it already today, but our colleagues, and particularly at the moment, I think exiting in inverted commas, coming through the pandemic, and I suppose exiting to a new way of working and a new world for the NHS, how we attract, retain, develop and motivate and enthuse our staff is really critical, and look after them. So there's a lot within this theme, but it is very much about those different elements of getting the right people into the organisation, keeping them here, making them want to come to work and do a fantastic job every day. And fundamentally that will then drive forward our patient care as well. And then the final one is just around our performance and our delivery. So obviously we've got constitutional standards that over the last year it's been quite different in terms of how those have been assessed and reviewed, and how we've been held to account for those. But going forward, obviously we need to reset, and very much our recovery programme has been about making sure that we're doing everything we can to meet those constitutional standards. And that is very much a part of our culture and our being. We set high standards, and that we deliver them, or where we don't, that we learn from that, and we're open and honest about that. So those are the 5 emerging themes that came out of the conversation so far. But as I've said, this is an ongoing process, and there's a number of additional discussions that need to be had. And when we share this with the wider organisation, we'll obviously reflect on their thoughts and feed that back into these proposed 5 emerging themes. I will pause there and take any questions.
Thank you, Louise. Joe, your hand's still up. Is it still up from the last item? Okay, if you could just lower it then, please. Thank you. Right, there's no additional questions. Louise, thank you. We've obviously been working on this a great deal as a board, but I think it's very important that the public are aware of the steps that we're taking in terms of developing our new strategy. And I think we're all looking forward to hearing the contributions from our colleagues, in particular in the forthcoming staff network discussions and forums that we're going to be holding. And I'm also pleased to note that we've got public forum engagement sessions as well, which any members of the public hopefully can engage with as well. So that's good news. Thank you for that report. If we're all done, thank you. We'll note that. We'll now go on to page 54, which is the National Integrated Care System and Integrated Care Partnership Report, being presented by our Deputy Chief Executive, Michael Wright. Michael?
Thank you, Chair. Just wanted to pull out 2 or 3 pertinent points from the paper. You'll see the successes on the final table around the vaccination across Rotherham, which is going really well. Also, across the place, there's a number of documents that are being updated and developed. There's a development plan, which is based on the ICS development matrix that we've collectively been working on, and we'll be bringing that back through the board probably in September for comment from colleagues. As the integrated care agreement, which was last in 2018, is part of an ongoing update. And also the Rotherham Place plan, the objectives are being reviewed at the moment, so I'll be bringing those back in due course. There is one item that's not in the paper that's just recently emerging, and that's the current review by Ofsted and the CQC of special educational needs and development across Rotherham Place. Our partners and ourselves have been heavily involved in that, particularly the 0 to 19 service, and Angela's been representing the trust, leading this for us. And at that point, I'll pause and take any questions. Thank you.
Thank you, Michael. Any questions or comments on Michael's report? Don't see anybody indicating. Well, thank you for the report. We're asked to note it, and quite rightly so, and you've referenced the fact that a key item will be brought back with regard to the Rotherham Place development plan to our board in the near future. So thank you for that, Michael.
Thank you.
Let's now move on to the board committee, assurance committee's chairs logs, if we could please. And we're going to start off with the finance and performance committee's log, page 58. And over to you, Nicola, please.
Thank you, Chair. Excuse me. Yes, we had a number of comprehensive updates this month at FPC, which included the community update on recovery and also on our financial projections for half-1. I think overall, as a committee, we had assurance both in terms of progress, but also on the focus across areas of the trust in managing some of the key risks, some of which we've already touched on in this meeting. The point probably to flag, and again links to previous discussions we've had as a board, and that's on looking ahead to half-2 and our medium-term planning. So we looked at the review of the cost pressures across each of the divisions, and also performance to date and the outlook around the CIP programme, the cost improvement programme. So we know these are areas that the executive are reviewing in more detail, and we've asked for an update at FPC next month in terms of what we're doing to address some of the issues, the projections, looking at cost run rates, etc., that could influence the financial profile of the trust going forward. So that's going to be an area of focus for FPC from next month. And I'll pause there for any questions or comments.
Thank you for that, Nicola. Stuart, anything you'd like to add before we open it up? Okay, thank you. Any questions or comments? Heather, please.
Yeah, I'd just like to sort of comment on what Nicola's just said about the CIP pressures and the cost pressures in the second half, because I think that is going to be a significant issue for us, and the CIP where we are actually at is going to make it even more challenging for the second half. And as we know, we've been operating at levels of cost pretty much set at our peak cost level for the last year and a half. So I think would welcome the in-depth analysis that's going to be taken to FPC next month, but maybe in the board papers there could be quite some detail about what that's actually showing the position to be for the next half year, so that if we are facing an uphill battle, we've got the time as a board to start addressing some what might be quite meaty issues.
Thank you for that, Heather. Yeah, I'm sure that can be done. There's no further comments on the assurance log, so thank you for that log, Nicola. Let's now move on to the quality.
Martin, sorry, I think Louise had her hand up. Apologies.
So it's just popped up then there, Louise.
Thank you, Martin. Thanks, Nicola. It was just to add, I suppose, and I don't want to be repetitive, but the point made earlier on by Richard, and then subsequently I've had a conversation with Stuart, is that in terms of the meeting we had last week, at that point we were obviously expecting the 85% limit in June, and then in July onwards, and we've recently just heard that's going up to 95%, which I think just in terms of also looking forward to the next month, we need to think about the impact on that in terms of our ability to recover monies that we have potentially committed to spend in, for example, the independent sector, and on extra activity, because I think it's quite a big difference between the 85 and the 95, and I think that will just be a piece of work that we ought to do relatively soon. So Steve, I don't know if you've got any views, but I just thought it was worth noting, Nicola, given the difference from when we had that conversation a week ago.
Thanks, Chair.
Steve, please.
Yeah, thanks, Louise, for raising that. My assessment of the position, having talked to Stuart and the team, is obviously this won't impact on month two's position on month three, but it certainly will need to be taken into account in terms of the forecast for half one. So when I meet with the team next week around the forecast position, we will definitely take that into account.
Thank you, Steve. Lovely. Well, thank you for your log, Nicola. Let's now move on to page 65, which is the Quality Committee Chair's log. Rumit Shah. Rumit?
Yeah, thank you, Chair. So I'll take the document and the log as read. I would suggest that it's quite a comprehensive but lengthy meeting, a lot of agenda items on it. But I'm quite happy to take any questions if anybody's got any after reading the document.
Thank you. Angela, is there anything you'd like to add from the Chair's log?
Just to identify the work that's ongoing around the reduction in pressure ulcers and in falls, and the quality improvement work that we're focusing on with the quality matrons, very well accepted and supported across the organisation, and I think that needs to be acknowledged as a good step forward.
Thank you. Can we just highlight that in the minutes, please, that particular point that raised by Angela? Thank you. I've got Lynn Hagger and then Callum Gardner. Lynn?
I just wonder if I could have a bit more detail on log item 13, where the committee had limited assurance because of the lack of resource in relation to clinical effectiveness.
Yeah, thank you.
Callum, do you want to take that one?
Callum, if you could take that and also...
Yes, yeah, no, absolutely. So, yep, no problem, Chair. So, yes, the clinical effectiveness team have a number of expanding roles and remits around things like TARN, which is the trauma network audit, and they've historically in the last 2 years taken on sequent activity and so forth. And there are increasing number of national audits, and their resource over a number of years hasn't increased. We did submit a business case, which unfortunately in the first presentation wasn't supported. We are just reviewing it at the moment, but what we're having to do is look at the current clinical effectiveness ask and make sure that we're focusing and prioritising on those things that absolutely make a difference to outcome. But that will inevitably mean that there are things that we might otherwise wish to do that we can't. The only other point I was just going to make, which was just a pure point of clarification, was on page 74 of the action log regarding medication safety quarterly reports and Rotherham Medicine's optimisation group. It will be chaired between my Deputy Medical Director for Professional Standards and Deputy Medical Director for Quality, rather than Associate Medical Director for Patient Safety, which is a post that doesn't exist anymore.
Thank you. Could you just clarify who that person is, please, Callum?
Yes, it will be Susan Douglas, hopefully from the middle of September, Chair.
Thank you very much.
And the former is David.
That's lovely. Thank you. I've then got Richard and then Heather.
Thank you. I was just reflecting on the content of this report and what it says about what we're focusing on through the Quality Committee, and linking that to where we aspire to be from a CQC point of view in the future. And I just inevitably, assurance committees tend to look at how we are now and how we've been, and retrospectively reports and harms. And I just wondered whether it might be helpful if we're aspiring to be good or ultimately outstanding. We know what that looks like from the CQC's description. There's in their ratings levels. I wonder if this. I'm just thinking about where we set the bar and the standard that we hold ourselves to, about whether or not we need to balance more towards a future focus of what we need to do than what the performance has been, from a cultural learning, QI falls into that, but more broadly than QI, more learning culture, and one focused on safety culture, not just harms. And so I know that some of that's implicit in there, but I'm just wondering if we, to get doing what we've historically done hasn't got us where we need to be. So it's just thinking about whether or not this is a discussion we've been having within the execs as well, and we touched on it a bit in the board strategy focus recently, but I just thought throw that in there just to provoke a little bit of a response.
Okay, Richard. Well, I think on the back of that, there needs to be perhaps some review of the forward agenda, doesn't there, in regard to what items we actually do look to bring forward to the Equality Committee. But I've got a few more people who would like to comment. I've got Heather, then Michael Smith, and then Joe.
Thank you. I'd just like to, I've got two comments now, because I'd like to comment on what Richard's just said, because I do agree that there needs to be forward looking as to what we're doing. And I think it may involve some different content, but I think also it can involve some of the content that we've got at the moment, but in a forward looking manner, as well as the retrospective looking manner. And it is largely retrospective looking. And I think I could move that into my second comment that I wanted to draw attention to, which is the medication safety report, which the committee was not assured with where we are actually on that. And I note that as Callum's just said, there's going to be some changes to the composition of that, but it's very much sort of like the pace and the ambition of what we're doing. It was highlighted by the CQC as well that we've got some medication issues. It's been coming in front of quality for, on a regular basis, but it's not been making significant progress. So the ambition to resolve the issues is not being dealt with at pace. And I think the two things can be brought together. I note that Callum is making some changes, but to get us to what good looks like, we do need to be focusing more on the we didn't do this, but what are we going to do and how are we going to accelerate it? And I think we could use this one as a particular case in point to move the agenda forward.
Okay, thank you for that, Heather. Michael Smith.
Thank you, Chairman. I was just struck by what Richard said, not only about the forward looking, but about the wider issues in terms of quality. There is some work by Aston University, I'll try and get a reference for it, that seems to show that those hospitals that have good staff engagement, who have other success factors to do with staff satisfaction and involvement, actually have lower death rates. So there's a holistic nature to the whole of the hospital in terms of quality. If I get the reference, I'll fling it through. Thank you.
Thank you, Michael. Joe Bibby.
Yeah, just say I really welcome the suggestion Richard's making. I think it's absolutely right. And maybe there's a kind of follow-on explicit question that the committee could think about in terms of the capacity and capability that would be required to move from, an insurance to a sort of learning culture model, because it will potentially draw on different skills and requirements.
Thank you for that. Well, thank you, colleagues, for all your contributions there. Is there anything further you'd like to add, Rumit, before we finish on this item?
So I'm very grateful to all the comments that have been made. I mean, I think to try and move on to the next bit of the agenda would be to say, well, what next in some of these quality issues that we're talking about? And up to now, what we've been receiving is obviously reports retrospectively as to what's been going on. But with the CQC report that will be coming out and what we already know, and with regards to patient safety and certainly incidents of harm, etc., I think you're quite right in asking that question about, well, what happens next? How do we move the organization from where we are to the next level? And I think I'll be certainly having those conversations with both Angela and Callum to be able to say, what do we do next in terms of content that we are getting at the quality committee from now on.
Okay, thank you for that. Just one comment I'd make, please, just on the terminology we're using. The terminology we should be using is assured, limited assurance, or not assured. And we've brought into this category some good assurance. So let's leave that out. We're just staying with the assured, limited assurance, or not assured, if we could, rather than grading it. Thanks very much. Let's now move on to the next item on page 81, which is the monthly integrated performance report. Michael Wright.
Thank you, Chair. As colleagues will see, there are 4 areas of escalation around mortality, diagnostic performance, and length of stay above 7 days, and also sickness, where we've seen a recent increase. In the normal way, Chair, I will invite the relevant portfolio directors just to give the headlines on their own positions, starting with Sally, please.
Thank you, Michael. So there's two escalations in terms of the operational performance aspects, as Michael's indicated, one in relation to diagnostics and the other in terms of length of stay and 7 days. From a diagnostics perspective, you've also got the detail in the pack. We've seen an improving picture, albeit quite slow on diagnostics. What within that we have seen is absolute recovery on endoscopy and non-obstetrical sound, which now have no patients waiting longer than 6 weeks, which is really positive. But in terms of imaging, we're still seeing a lot of challenge in terms of capacity to clear backlogs of patients. The key challenge we've got is around MRI, where we're forecasting now recovery by year end, but we're trying to bring that forward sooner with additional days of our mobile scanner on site. So recovery is dependent on the additional mobile days, but we have got that planned in and we're working with that provider to make sure that we've got that capacity and in the right areas. In terms of length of stay, we're doing a lot of focused work around discharge. We've already touched on it a little bit in terms of work with partners as well, and there's more to go. We've held workshops with each division now, and with good engagement from the heads and AFSINs and ward leader. We're seeing some improvement in 7 day length of stay, and at times we're well within national ambition across all our length of stay metrics. But what we are seeing in terms of 7 days is the dependency and complexity of patients that are coming through for admission, and that is presenting us with some challenge. So there's a lot of work taking place to bring that down, and we're working with the national team as well in terms of some of the experts we can draw in terms of some of this work. There are aspects of discharge that we're doing really well on, and we've been asked to present regionally, but 7 days is still presenting as a challenge.
Thank you, Sally.
Thank you. Could I, Angela now, please, Chair?
Thank you.
Thank you, Chair. To identify around quality for this month, infection control, we're still in a strong position from an infection control perspective. C. diff, just one case that has been occurred this month, and we are reviewing with the CCG, sorry, to identify whether there's been any lapses of care, and we'll take that through appropriate processes. From a patient safety point of view, we've had BT assessment target for the first time in 2 years has been reached, and that has been supported by all the work that Callum's been doing to support the teams and making sure that we're doing those assessments in a timely manner. Readmission data is obviously off track at the moment, and we're wanting to do some more work with the CSUs to ensure that we've got that understanding of all those cases and why they have been readmitted, whether there's anything that we should have done at the first time they were with us to make sure that they don't get readmitted and have further hospital stays. And maternity has provided a strong month from a KPI perspective this month. Unfortunately, we did have an neonatal death in May, but we have met the targets that we needed to across the board for this month. Maternity safety champions have continued to meet and undertaken walkabouts, and you'll be aware that maternity visit by the CQC as part of the well-led inspection, and the feedback from that visit to date has been positive.
Thank you, Angela. Could you just clarify, I think you mentioned CCG, the clinical commissioning group, and
yeah, sorry.
Okay, and C. diff, please.
Sorry, Clostridium difficile, which is a bowel issue that we have from an infection point of view. So we manage it with isolation and making sure that patients are treated appropriately from an antibiotic point of view.
Thanks very much, Anne.
Yeah, so CCG is Clinical Commissioning Group. I was getting my CCs mixed up.
That's no problem. Thank you very much. Back to you, Michael.
Yeah, thank you. Callum, I'm very conscious you have a separate paper later on that covers mortality. Is there anything you would wish to add on the quality side?
Yeah, I think the two things really is just draw board colleagues' attention to venous thromboembolism risk assessment compliance that we've had sustained above 95%. It continues to be a standing agenda item on my clinical leads meeting. All clinical leads now get access to their own data so they can make sure that they're making improvements. And I think the other thing to say is I think that whilst we have ongoing challenges in terms of activity and so forth through the organisation, I think it's reassuring from my point of view the number of tiles from a quality and safety perspective that have flipped green and stayed green. And of course we will continue to improve matters so that we flip all tiles to green where at all possible, and even where we are achieving the target.
We've just lost you there a moment, Callum.
Yeah, Chair, shall I move on to the next area and maybe come back to Callum?
Yes, please.
Thank you. I'd just like to invite Steve Nedding, please, to touch on some of the workforce metrics, particularly the sickness. Thank you.
Thanks, Michael. So just, I think, focusing on sickness, which has seen a notable increase across all divisions this month. We utilised the opportunity of the performance review meetings with divisions this month to have more of a conversation with them around assurance that they are managing sickness absence appropriately. And I think from an executive team point of view, we were assured that they're on top of it. They understand what the issues are. There's been a noticeable rise in long-term sickness, some of it anxiety, stress and depression related, a lot of it that anxiety, stress and depression is related to issues outside of work rather than in work. There's also been a number of staff off long-term sick with other illnesses or conditions. I think the conversation we had with the divisions was we're assured that they're managing the process in terms of following the procedure, meeting with staff, understanding the issues. I think what we're looking for going forward is more of a focus, given the conversation we had earlier around prevention rather than cure. So it's about the health and wellbeing initiatives and trying to support staff not needing to go off sick in the first place. Obviously some sickness is inevitable, but we're trying to shift the focus of the conversation rather than looking at the policy and procedure and taking people through a process to having supportive conversations through health and wellbeing discussions.
Thank you, Steve. Right, well, we've obviously heard the escalations. Do we have any questions or comments on those, or indeed any other items in the integrated performance report, please?
Chair, I do wonder, could I just maybe give Stuart or Steve the opportunity to comment if they would wish to about the finances?
Yes, of course, thank you.
Shall I go, Michael?
Hi, Michael. Sorry, go on, Steve.
So the position presented is at the end of May.
Steve, I'm sorry, we can't quite hear you.
Is that any better?
No, not yet. Okay, well, what we'll do, we'll pick up any questions while we get the technical issues resolved. Heather, you wanted to comment, please.
Yeah, just a couple if I could. I think on page 88 in the bottom section of community care, the CC3 and CC4 in the cumulative position, that's just an addition of the 2 months, and it's always going to be red if that's the case. And I think if we're looking at the sort of average of what we've actually achieved compared to the target, it would be green. So you might want to have a look at what we're actually reporting on in those 2 items. But the question I wanted to ask, which is quite a long way off where we should be, is again in the community, excuse my pronunciation, the musculoskeletal physio, which is way off target. Have we got a specific problem there, and do we have a plan to address it?
Okay, thank you, Heather. I've got Callum coming back in. Callum?
Thank you, Chair. I was just going to come in about the CC3 and CC4, Heather. So yes, I agree with your point about the cumulative total. Just to say that as part of the medical examiner reviews on a stage 1 review form, they now, as I think I might have highlighted to board colleagues previously, also look at death was not just avoidable, but whether the admission could have been prevented by giving a patient greater support in their care home, for example. So we're just looking at pulling the data through to inform discussions with place partners.
Thank you. Were you able to address the other point that Heather mentioned? Or if somebody could?
Because you would know, Chair, I can't, sorry.
I've got Sally.
Yeah, I'm happy to come in on that.
Thanks,
I'll
Sally.
further detail in terms of MSK, but what we are seeing is some real pressures on community services. So we are having a discussion with Penny and community about where they are on some of their access metrics, and particularly continence, the one below. They've seen some real challenge. The number of referrals they've had in this month, so even this week, doubling what they've previously seen. So they're doing some detailed work at the moment in terms of understanding what's coming in and really looking at what the workforce is that they've got to deal with it. So it's work in train. I can't answer specifically in terms of the detail, but they are on with that.
Thank you. Angela?
Thank you, Chair. Just to come back on the back of Sally's comments, MSK has had some challenges around staffing, but also the increase in referrals that we've seen. And also from a continence point of view, been talking to the division around the allocation of continence advisor for the acute, so that we can actually do some of the work within the acute setting while as inpatients, and arrange for trials without catheter or changes of catheter before they actually get into the community. So it's more of a managed system. So that should see an improvement going forward.
Thank you, Angela. Rumit?
Sorry, Chair, just a last point. So primary care networks should have additional roles, and particularly physiotherapy is one of them, whereby, in fact, what you should see in the MSK service is a reduction rather than an increase in the throughput. So just need to probably understand what exactly it is that is being referred in and why we're not managing to meet those targets, to be honest.
Okay, well, that's helpful, Rumit. Thank you for raising that. Sally, did you want to come back again?
Yeah, well, just to add to that point that Remit's made, we have had discussions with partners around that, and what they're finding as well is all the capacity that they're putting out in terms of extended access around physios is being fully utilised. They've put additional capacity in to meet demand, and they're also seeing that that's as fast as they're putting that capacity and it's been taken up. So we're having discussions with partners together.
Okay, well, thank you. You obviously will be focusing on that issue and keeping a close eye on it. Thank you. Are we able just to address any financial points that our Director of Finance would like to raise?
Thank you, Chair. Can you hear me now?
It's a little better, but still very low.
Sorry, Chair, I'll try and address it. Just to point out that month two's financial position is favourable, 519,000.
That's better. That's much better. Thank you.
Thank you, Chair. The capital position is slightly overspent, but not worrying at this point in time. So it's a minor change in terms of the financial position at month two. Cash very strong at £23 million in the bank. So that's a really good position to have at this stage in the financial year. And as we've already touched on, at this point in time, our cost improvement programme is behind the curve in terms of the plan. But in talking to the team yesterday, there are a number of schemes that have been able to be transacted in month three. So I'm hopeful that that will be an improved position at month three when we report it next time. And I'll pause there, Chair.
Okay, thank you. With regard to the cost improvement programme, obviously for the full year, are you confident we'll be able to address and get to the target that we've set ourselves? That's the key thing. I appreciate it may well be slightly behind at the moment, but are we committed to ensuring that we do achieve that?
I think in terms of conversations with the team, it's a stretch target for the back end of the financial year. So half two is more challenging than it is for half one. So I will be having further conversations with the team in due course, Chair, around the achievement of that. I think it's fair to say it will be a challenge recurrently for the organisation for this year. Possibly we could deliver that non-recurrently, but from a recurrent point of view, I think that will be a challenge.
Well, thank you for highlighting that. Notwithstanding it being a challenge, clearly as a board, it is something that we've committed ourselves to in terms of our own outcomes, and indeed as being a partner to the ICS as well. So I would like to that to be addressed, and for us to get a clearer assurance in the next few months with regard to that issue, so that we understand what it is we might have to do in mitigation in terms of actually delivering our plan, if we could, please. Michael?
Thank you, Chair. I chair the CIP Efficiency Board, and we've had the same conversations, and we've been asking divisional and corporate colleagues around their levels of confidence of hitting their own individual targets. The level of confidence is certainly growing, but I think, as Steve said, it's still going to be a challenge in the second half. So we'll continue to progress that and report back to board. Yeah,
if you could bring us a timely report to the board well in advance of knowing what the outcome might be, as opposed to it being near the year end, I'd be grateful. Thank you. Right, looks like we're all done on that item. I've got no further indications of any comments. Thank you all for your contributions and the work that we've done there. Let's now move on to page 102, which is the Reset Recovery Operational Report. It was produced by our Chief Operating Officer, but our Deputy Chief Operating Officer, Sally Kilgallerth, is going to lead on that report for us. I'd like to highlight any key points, Sally. Thank you.
Thank you. I'll take the paper as read. I think just overall what I would say is you can see there's an improving picture in terms of recovery. Despite the challenges we've seen in non-elective care and urgent care, which is obviously significantly up on demand, as is the rest of the NHS, we've seen a lot of elective recovery. I think what I would just point out, as is highlighted, we are in the top 5 in terms of acute combined trusts in terms of our elective recovery, which is a great achievement. And I think in terms of senior managers and the questions we asked earlier, I think that's done a real boost for them to see the performance that we've achieved and what difference that's made for our patients. One thing that's not in the report I'd just like to note is the discharge lounge has opened. That's snuck in at the end of the reporting period we're covering right on the 31st of May, and that's up and operational, and it's a really impressive facility. I know we've got a board assurance visit planned for there this afternoon. So yeah, improving picture, as has been pointed out, that moving forward, that's going to be dependent on COVID. At the time of writing of the report, we were fairly stable in terms of the numbers. And as has already been pointed out, we're starting to see that increase, which will present us with some challenges moving forward. Happy to take any further questions.
Thank you, Sally. No, good report, thank you. I've got a couple of colleagues who'd like to question and comment. Lynn Hagger and Heather Craven.
Yes, thanks, Sally. It is a good report. If you could just provide a bit more detail on why ophthalmology is off plan and the steps being taken to address that, please.
I'll just bring in Louise, if that's all right, on that one.
Yeah, that's absolutely fine, Sally. So, Lynn, I think that related to a couple of specific issues. The first one was around a piece of kit that we were planning to buy, which we've now purchased for the for part of our recovery, but there was a longer lead time than we anticipated, so it won't be here as soon as we had hoped, but that has now been ordered. And the second piece was regards to, and Callum, feel free to jump in, but a locum ophthalmologist who we were planning to bring on board in July, who unfortunately is no longer able to join us, and I think that relates to visa challenges. Which obviously does have an impact in terms of our capacity to deliver additional activity. So the team are looking at what else they can do with the existing resources, but unfortunately, part of that is related to the pandemic and was out with the control of the division, unfortunately. So those are the two specific issues I think that relates to.
Thank you. Callum, would you like to comment on that? Callum?
Yes, Louise is quite right. That was one of the reasons. We're also about to lose one of our ophthalmologists in terms of planning, so we're going out to advert imminently for that, and we're discussing with Barnsley colleagues to see how we might do it. Sorry, can you hear me?
It's a bit intermittent, Callum.
Can you hear me?
Going. Yeah, it's intermittent, but keep going.
Sorry. Can you hear me now?
Yeah.
Okay, I said that Louise is quite right. A colleague wasn't coming as predicted. We're going out to advert shortly to replace our clinical lead that's leaving, and we're also talking to Barnsley colleagues to see how we might be able to support each other with mutual aid.
Okay, thank you, Callum. Heather?
Thanks. There's some, excuse me, there's some really great progress in there in all sorts of different areas. But the question specifically is around UECC and what's a really quite major increase in walk-ins and minors, which is placing huge pressure on the staff and the ability to cope. So do we have any understanding as what's actually driving that and whether we can do anything maybe further back down the line to reduce that pressure?
Yeah, there's a number of different aspects, and some of it we're seeing increases in primary care attendances, and we've been working with primary care colleagues in terms of access in primary care and alternatives. Some of it is minor injuries, and whilst it's not majors, there's a lot of injuries which are appropriate to us. And again, we've been putting additional resource in terms of that front end to see those patients where we can secure additional workforce. And we're also seeing increases in paediatrics, which we touched on earlier, both in terms of respiratory illness and CAMS patients and mental health. So we're working with our DASH very closely in terms of capacity to support there. one of the things that we've been doing around that increased attendances is really trying to strengthen the processes we have when patients present at the front door to ensure that they're seen quickly, triaged and streamed to the appropriate area. And that work's been ongoing with the team, and we've had good engagement, and we're working with the staff that are actually working on the ground to drive the improvement that they want to see, to be able to see patients quickly through there. But that all of that doesn't get away from the demand that's coming through with the pure volumes, which are presenting a challenge. They're doing everything they can. We have managed to secure some additional GPs and AMPs on the front door, and we've worked with other providers to support us with that. So that's been positive in terms of that extra workforce.
Are we seeing any reduction from the work that we've done with the primary care streams?
I wouldn't say as yet we're seeing reductions in attendances, and what we are seeing is variability in terms of the times of day when they're presenting, which is we're seeing surges in demands at particular times, which is becoming difficult for us to manage. The bit that we're trying to be really proactive around, and again, but is increasing, is also 111. So the 111 first work where patients ring 111. So we are starting to see increases through there, and those patients booking directly. And again, we're trying to manage patients' expectations in terms of when they present. And so there's lots of work with partners.
Okay, thank you. And finally on this item, Jo Bibby.
Yeah, thank you. I mean, first of all, really good to see the progress being made. It's so important to be working on the backlog. The one thing I wondered if it would be possible to have any information on now or in future is how this is being looked at in terms of equity. And because I know the NHS England guidance talked about ensuring that the backlog was treated in a way to reduce inequality. So if there's anything that can be said about that now or next time, that would be interesting.
Thank you. Louise, would you like to comment?
Absolutely. Thanks, Joe. It's a really good question. And you're absolutely right that that's something that we're looking at. The ICS have done a piece of work across the system. So I think they're quite keen to look at this, understandably, at a system level. And we're providing data to them, quite detailed data, but non-patient identifiable, obviously, to enable them to do that at system level, which we've started doing. I think it was about 2 weeks ago now. So I haven't yet seen the outcome of that work, but I'm sure that will be with us shortly. Second to that as well, the CCG have done a one-off piece of work to look at, as you've said, kind of the distribution of the waiting list and whether there are any differences, particularly in terms of access and equality of access by deprivation level. So that's something that we've done. What we haven't yet done and what's in our kind of programme of work for the next 6 months is to look at a number of different factors in terms of patient demographics, not just indices of deprivation, but actually other elements as well around ethnicity, et cetera, et cetera. And we've said we will do a one-off piece of work in October, and then we'll build this into our normal way of working and our sort of BAU practices in terms of how we review the waiting list from that point. So absolutely, it's on sort of the short-term plan for the next year.
Okay, thank you for that response, Louise. Angela?
Thanks, Chair. Just to come on the back of that with Louise as well, as part of the role of the Equality and Inclusion Officer working with Emily Raw from an equality and diversity point of view for the organisation, we obviously have to do our review of access to services and our demographics at year end, and we're going to be building on that over the next year to identify that we can be very specific around as an overall for the whole year, whether we've had any issues around access from an equality and diversity point of view.
Lovely. Thank you for that added information, Angela, and thank you for your report, George and Sally. That's been very interesting, and it's good to see the progress that's been made. We're just going to take a natural break now, colleagues, if you will. It's 11:04. We'll come back online prompt at 11:10, please. 11:10. So we'll just take a natural break. Thank you. Agenda. Sorry, recording. Recording started again. Thank you. Welcome back. Let's now go to page 111, which is the Care Quality Commission report, and Angela Wood, our Chief Nurse. Angela?
Thank you, Chair. So colleagues will be aware that we've been having inspections by the Care Quality Commission over the last couple of months. We had an unannounced inspection in May where the team visited our acute medical unit, our UECC and Children's and Young People Services. We were then identified to be having a well-led review the 22nd to the 24th of June, which went ahead, and at the same time an unannounced inspection of maternity service was undertaken as well. You'll note on the appendix there is a letter from the CQC giving us high-level feedback around the 22nd to the 24th of June visit, and last month we provided an update from the original May unannounced inspection. Action plans are being developed and just finalised around the verbal feedback and the written feedback from the two letters, which will be presented to Quality Committee next month. And the rest of the information in the report identifies the other inquiries that we've been having through the month around different issues. Also, I can be confirming today that all of the requests for information from both the unannounced May visits and the June well-led and maternity visit have been submitted as of today. I've checked all of the information and it's all gone down the portal. So that's a really positive position for us to be in. Just like to note for colleagues that Anne Rolfe, our Quality and Compliance Manager, is leaving and is the last day today. And I just wanted to acknowledge all of the work that she's done to support us and get us in the position where we've completely submitted all of the information requested to the standard that was required.
Thank you, Angela, for your report. And just before we move on to any questions or comments, let's just record our appreciation in the minutes of Anne Rolfe's contribution as our quality manager with us for a few years, and wish her every success in her new role at Chesterfield Royal Hospital. So thank you for highlighting that, Angela. Just bear with me, we've got a number of people who would like to comment. So I've got Nicola.
Thank you, Chair. Angela, section 2.1 of your report and the review by 360. So it's really positive to note some of the staff engagement that they observed and the best practice. I know you mentioned about specific learning that needs to be undertaken by the organisation as a result of their review. Anything that you'd want to highlight to the board in terms of key learning that they flagged as part of their review?
Yeah, thank you, Nicola. So 360 were commissioned to undertake a review from a CQC point of view around the time of the unannounced inspection. And we thought it was a really good opportunity for us to utilise that time in their diaries, look at the feedback we've been given from the May inspection and identify whether we'd address the issues that they raised and whether there was any other learning, as you say, that we could get from it, and make sure that we were fully implementing any suggestions. So they did an extensive review over UECC, AMU and of the children's wards to identify some of that initial feedback that was verbal and in that written letter from last month. And we identified there were still some processes that we needed to strengthen and some differences in the way we were managing some of the areas. So for an example, fridge temperatures, we had a different form across the organisation in different areas. We've now standardised that based on the information we got from 360. So they identified that we were carrying out the checks, etc., that had been highlighted by the CQC, but that it was a different process or a different reporting, if you like. So that's now been identified. We picked up, while we were going, some issues. We talked about oxygen storage, and the CQC had fed that back to us. We've now got a consistent approach around that and the labelling and the collection. So I think it was real good, useful for us. It gave us some real positives to get back to the staff. They had addressed the issues, and that gave us some assurance from an exec team point of view that those issues had been taken forward very promptly and had been resolved. And anything that wasn't quite there, we made sure that that feedback was given. But there was a communication across the divisions as well, so that they themselves then could make sure they were up to date with what had been identified. So I think it was an opportune time for us to be able to do that. And I think it gave us some real good assurance that we were actually addressing the issues and taking things forward.
Thank you, Angela. I don't have anyone else's hand up at the moment. So thank you for your report, Angela. We note that obviously we'll be receiving the formal report from the Care Quality Commission in a few months' time, and obviously that will be reported to the board on that occasion. So thank you for your report, Angela, and indeed for all the work that you and all our colleagues have done in responding to the CQC, the Care Quality Commission, during their inspection. And it was pleasing to note that they welcomed the positiveness and openness of our colleagues during their inspection. So thank you for that.
Thank you, Chair.
Let's now move on to page 118, please, which is the Mortality and Learning from Deaths paper. And that's going to be presented and highlighted any key points by Callum Gardner, our Medical Director. Callum, please.
Thank you, Chair. I've turned my camera off just to try and help the bandwidth. So hopefully colleagues will find that the report is consistently hitting the mark more than perhaps previous reports. You will see the HSMAR is 125, as I've previously highlighted. Almost certainly this is due to the COVID impact, and we are unlikely to know the true picture of HSMAR for probably the next 12 months. What I can say is that SHME continues to be within the expected range. And in fact, hot off the press, our SHME is now below 110, it's 109 point something, and our SHME is lower than colleagues such as Doncaster, Kettering, and indeed my own last trust at Northwest Anglia. And that, just to highlight, bearing in mind it's a 12-month rolling average, represents a 12-point improvement in under 8 months, which I think is a significant improvement and would certainly suggest that we're going in the right direction, particularly as SHME is not impacted by COVID. Just a couple other things to highlight. Mortality Improvement Group continues, likely to continue probably for the next 2 or 3 months, and then very much be absorbed into business as usual. You will see about the mortality alerts that have appeared. They are being taken through our new stage 3 review process that we've put in place, including with input from the respective clinical leads. And a lot of work continues to try and strengthen our learning from deaths, particularly at a specialty and divisional level. And I'm very much aiming for when our internal auditors re-audit learning from deaths later in the year, that we get a good assurance rating. Happy to take any questions.
Thank you, Callum. A question from Joe Bibby.
Yeah, thanks, Callum. Just had a few questions actually. So thank you. It's really useful seeing this report so often, and really good to see the priority being placed on this. There was one thing, and apologies if this is something you've explained kind of at previous meetings, but I thought it was interesting that you said we're one of 8 trusts within a peer group of 13 that are showing higher than expected, which kind of then starts to beg the question, is this something about the sort of calculation? So I was just wondering if you had any reflections on that. The second thing was also sort of noted you weren't able to appoint to the, I think, associate director role, or whoever was going to take a lead on this. And I wondered if there was any external sources of support that the trust could be drawing on, like the Yorkshire and Humber Improvement Academy. And then my third question was, I mean, there's a lot of work going on, which is really good to see. What I suppose I couldn't quite see in the report, and I wondered if you had a feel for at all, was the kind of relative contribution of the different efforts that are underway to sort of making that overall shift on the position, and whether there might be a way of displaying that through a driver diagram or some sort of visual that would help see how these different things are contributing and lining up.
Thank you, Joe. 3 very good questions. So the first one around the expected mortality rate calculation. We have a lower expected mortality rate than colleagues at Barnsley and Doncaster. despite having very similar levels of socioeconomic deprivation, etc., all of the things that are used to calculate what is expected. But what our own trust's expected mortality rate is nationally calculated. And whilst you're right, it does appear to be slightly at odds, that is what has been calculated for our organisation. And certainly there have been times where, certainly in the recent past, where the number of deaths or deaths over and above our expected mortality has been lower than, for example, Barnsley's and Doncaster's. But because we've got a relatively lower expected mortality rate than they do, the negative impact on our HSMR was much greater than theirs. But as I said, these are nationally driven, and I have had a number of conversations with Dr. Foster and Lisa Fox, who's our health informatics analyst, really whether we can influence that, and the answer is no. So it is what it is from that point of view. In terms of the mortality lead role, we do have a mortality lead role in the sense of Dr. David Black, who's my Deputy Medical Director for Professional Standards. You're quite right, I did want to recruit an Associate Medical Director for Mortality and Learning from Deaths, and unfortunately was unsuccessful on 2 occasions. But I've now tweaked the job description, and I'm looking to go out in the near future for a clinical lead, which will be open to band 8As and above, and not just medical staff. We have had a lot of very positive support over the last 2 years, where I've been doing a lot of work on mortality from the Yorkshire and Humber Improvement Academy and NHSIE colleagues. I've contemplated whether to go out for an external advert for this role. I think the difficulty is because it's a 1 day a week role, you'd want to appoint someone substantively to do something else, for example, a consultant in a particular specialty, and them having them do this 1 day a week. I think it'd be very difficult to do this job 1 day a week and not work in the organisation the rest of the time, because a lot of it's about relationships, communication, engagement with staff, and so forth. But nevertheless, continue to pursue having a separate lead over and above David and I. And the third thing about the relevant contribution, I think that's really difficult. I don't think there is an easy way of demonstrating by having done X, it's had that, this impact. What I can say is we've continued to focus on what we've called the 3 Cs. So that's very much around quality of care, case mix of patients potentially being admitted and die within 24 hours who could, as I said earlier, be supported in their own homes or in their own care homes. And the third element is around coding. I think a lot of the improvements we've done in coding, I think, have had a lot of impact. R was below 100. There are still opportunities and areas for improvement around quality of care that we need to continue to do. Hence why I've never wanted to get particularly fixated on the numbers, but to continue to try to make improvements. And that is around things like end-of-life recognition, schemes of care, introduction of respect documentation, etc. But I think it's really difficult to present. It's probably a multitude of the things that we're doing that's having the desired effect. And clearly we want to continue to do that until both HSMR and SME are well under 100 and stay there.
Thank you, Callum, for that. Sally, please.
Yeah, just a question for Callum, thank you. It's just in relation to, I've touched on the work that we're doing with partners, and we're doing a lot of extensive work with partners, and one of which has been the hospice, given the pressures that we've had. And our consultants work across into the hospice as well, and our team are working really closely. Do you get a sense, is there anything further we need to be doing operationally, Callum, with partners and hospice into patients' preferred place?
Yeah, yes, I do. So I think there's a couple of things there. So in terms of the hospice capacity, there's certainly a feeling across place that there is insufficient hospice capacity. That's been further negatively impacted clearly as the hospice is a charity. And of course, during the pandemic, their income has been impacted. They are doing a piece of work at the moment looking at the bed base. And I think we need to, in fact, we were talking about how we can feed into that yesterday, very much to influence that discussion with commissioners at a place level. One of the things that my intention is to, for us to be able to access that will enrich that conversation is on the stage 1 reform that I talked about earlier, collating data that says the death might have been unavoidable, but was the admission potentially avoidable, as in could we have supported someone to die in their own care home? Because there has been the ability hitherto to have blank boxes. So health informatics team are very much working at making all of those boxes mandatory, so you have to put yes or no, and also to break down by care homes so we can see is there areas that our community teams, etc., can help support more on. Just in terms of the palliative care resource itself, nursing-wise, we're now fully recruited in the back of the business case, which will significantly strengthen our acute support. Medical-wise, our resource has always been in the hospice rather than in the acute. We have seen a very positive impact during COVID when our palliative care consultants came onto site, and that was really, really positively received from staff and indeed relatives. We are out to advert currently for 1.5 extra palliative care consultants. Unfortunately, we weren't successful at recruiting the first time, but we will continue to do so until we're fully recruited to that additional resource that the board colleagues kindly approved.
Thank you, Callum. Thank you for your report and indeed for highlighting the various progresses that we're making in that regard. So we're asked to note the mortality position and the significant actions being taken to make improvements. So thank you for your report, Callum, and the work. We're now moving on to the compliance with regulatory and legislative frameworks report, which is a report from our company secretary and director of corporate affairs, Julie Dawes. And this paper came out separately, so it's not actually part of your pack. So if you could just reference that paper, please. And Julie, if you could highlight any points you want to make to the board. Thank you.
Yes, thank you, Chair. As you will be aware, this report it's a fairly regular report. It was previously reported in the confidential section, and the intention of the report is to bring together all the strands of areas where we have to comply with either legislation or regulation and various frameworks. So primarily with our NHS providers licence, with the CQC and the NHS oversight framework. And also in addition to that, where we have to comply with various regulatory bodies. So it's just a summary in terms of what we've achieved over the previous 6 months. We last reported, I believe, back in March. And then in December, there was a decision that rather than reporting the confidential section, we felt that this is something we should share with members of the public as well. So I'd like to draw your attention to probably section paragraph 2.6, which relates both to our undertakings for our provider licence and also our compliance with the oversight framework. And essentially, as you all know, as previously reported, we're in dialogue with our regional director and also NHS Improvement I in terms of lifting those undertakings, and we feel that hopefully a decision will be made fairly shortly as to how we move forward with that. The rest of the report I think is fairly straightforward, and happy to take any questions or comments.
Thank you, Julie, for that report and indeed for bringing that into onto the public agenda. Michael Smith.
Thank you, Chair, and thank you, Julie. The timing was appalling, but I was just wondering about update on the health and care bill.
I'll refer
Where
to
will
that.
that go to?
Yes, that's referred to, well, it's not referred to, but that, I'll pick that up in my next report if you like, because obviously that's a publication, you know, obviously changes the direction. So I'll pick it up in the next report, the next governance report.
Okay,
This one's
NHS
about
providers have got a useful summary if anyone needs it. Thank you.
Yeah, but this particular report's focusing on our regulatory and compliance issues. So let's just keep the focus on that, if we may, and pick up any other issues later. All okay with that report? Happy to note the progress that's being made and our position at the moment. Thank you, Julie, for your report. Not long to wait for this next item then. This is the governance report, again for information, which is enclosed within our pack. Julie?
Yes, thank you. So the difference between this report, this is in relation to sort of developments, publications, guidance, policy changes that have taken place since the last meeting. And yes, thank you, Michael. Obviously, following this sort of circulation of this report, the Health and Care Bill was published, I think, on, where are we, on the 1st of this month. So It's not reflected in this report. There will be further details in the next report that I bring to the board. Happy to share a copy of the Health and Care Bill. I think our exec colleagues have received it, but certainly non-exec directors, I can send through the briefing note produced by NHS providers. And I think one of the things I will say, I mean, obviously the report covers a lot of material. There's been a flurry of activity in terms of publications to do with the ICS. Obviously, we've had the design framework, which came out last month. And then during this month, we've had the oversight framework and the metrics, and then obviously the Health and Care Bill. As a board, I think we need to spend some time in terms of making sure that we've got the opportunity to digest what's been said, and also to make sure that we can work out what the implications are going forward, particularly in relation to decision making and how decisions will be made at organisation level, and also how things get escalated back through to the ICS or at place. So I would imagine going forward over the coming months, we will spend a little bit of time either in board development or in a workshop mode, trying to make sure that we've got the opportunity to sort of pick up in more detail on some of those areas. Wasn't intending to say much more, apart from in terms of from a decision-making point of view at organisation level. I would imagine that we would have to sort of have a review of our, not necessarily our standing orders, but certainly matters reserved for the board, our scheme of delegation, and probably our SFIs to work out what authority levels we have at trust level, and then in terms of what things need to be approved up at ICS level, how that's actually handled within the organisation. But certainly we'll provide further information on that as and when we've had time to work that through. The other point to mention in terms of a possible change, which I think we touched at our development session on Tuesday, is in terms of our constitution and what may come down the line in terms of membership and governors as a result of this sort of ICS environment as that evolves. In terms of the metrics, the oversight metrics which were published as well last week, I think obviously in terms of our IPR, we will be looking at how we will need to change our reporting sort of going forward, you know, in future months with the board, but that's something that's been looked at by the exec team as we speak. Happy to take any questions on the report or, you know, receive any comments. Thank you.
Thank you, Julie. With regard to those points that you've highlighted, can you make sure that they get annotated for our forward work programme for the board, please,
Absolutely.
so that we don't miss them? Thank you. Lynn Haggart. Lynn?
I think mine's more a question for Ian, in that just to get a sense, without being overlong about it, where we're at with our net zero plans and how will that be monitored? Is it going to go through FMPC?
Thank you, Lynn, and thank you, Chair. Yes, I'm working up plans to present a paper to ETM initially with regards to the appointment of specialist consultants to help us with this quite technically complicated matter, so that we can develop a environmental sustainability strategy that will help us meet with the net zero requirements as set out by Sir Simon Stevens.
Thank you, Ian. Thank you for your report, Julie. I have no further questions on that. Thank you. The next item is the Quality Committee Terms of Reference, and there's a proposed amendment to the Terms of Reference. Angela Wood, our Chief Nurse, could you just make that recommendation to us, please, Angela?
Yes, thank you, Chair. So we reviewed the terms of reference at Quality Committee and identified we needed to change some of the operational groups that report to the committee, some of the way that's described, so Infection Prevention and Control Committee rather than just Infection Control Committee. Ethics group needed adding as well. And then to identify that a chair's log in the prescribed template is required from the meeting rather than a chair's report. those were the identified changes in red within the terms of reference submitted, and we would like approval, please.
Thank you. Lynn, your hand is up. Are you wanting to speak on this one?
Yes, it's not a legacy hand. Page 139, your reference to ethics group, Angela, it needs to be clinical ethics group.
Okay.
Thank you.
Thank you.
Thank you. With those, that sort of additional point from Lynn, are we all agreed that we approve the revision to the terms of reference for the Quality Committee? All agreed? Thank you very much.
Thank you.
I have any other business. The date of our next formal board meeting will be the 10th of September. Can I just ask, is Gavin still on the line?
I am, Chair.
Governor. Gavin, do you have any questions or comments you'd like to make before we close the meeting?
No, not today. Thank you.
Well, thank you very much for joining us. We do appreciate your time. Thank you. Right, colleagues, that ends the public board meeting for today. We obviously have been working half an hour later. So in terms of starting our next meeting, would you be comfortable if we start that at 12:30? Does that fit with everyone? All right, have an hour now. That would be good. Thank you. So I look forward to meeting you all again shortly. Thank you for your time.